And very good afternoon, everyone. After yesterday's session of suturing hands-on, we are back again at the Osstem Center for the demonstration of implant placement of Osstem TS implant on these beautiful models created by Osstem. I'm Dr. Varun Prabhavalkar, and I'm over here as a trainer for our basic masterclass in Mumbai for Osstem. Model we have, can I have a pen please? Model we have in front of us are styrofoam models, okay? We are going to do two demonstrations, one for the delayed implant and one for the immediate implant, okay? The choice for the site is going to be one over here, that is a premolar, and another one in the central incisor where already existing socket is there. I'm going to take a blade, and to save myself the trouble of reflection, I'm going to remove this entire part of the gums. Please do not try these things on patient. This is for the sake of clarity only, so that you can see the part of osteotomy very clearly. There you go. Once exposure is done, understand that the most important thing for the implant placement is not digging the hole in the bone and placing the screw inside. The most important part over there is planning. Now just imagine that now we do not have a planning done for this particular patient, but we are going to focus over here on technique because of that. We are going to have a premolar set, and our position is going to be only prosthetically driven, and for that matter we are going to mark our premolar, imaginary premolar first. When we check out the occlusion, we see that vertically the space is enough and mesiodistally the space is enough. That means this imaginary space, which is also known as prosthetic envelope, is sufficient for us. Our axis of implant will go directly to the center of this imaginary space for the crown, also known as prosthetic envelope. Over here, I would like to mark my premolar first, and I would like to mark mesiodistally. That should be approximate width for the premolar. Center of that particularly is going to be this region, okay? This is to be imagined by the operator in the patient's mouth, okay? And if I see buccal and lingual cortical plates, I determine this to be our center. That's the marking, okay? So we are going to start drilling through this particular marking. Again, in the patient's mouth, okay, you need to make sure that this is at the center, and this entire exercise of osteotomy should be, again, prosthetically driven. What we have in front of us is a taper kit. Can you please focus on this? What we have in front of us is Osstem taper kit. This is the most advanced kit available in the Indian market, and why I call these things is because it's the most elaborate kit, and they have depth-driven drills, as you can see, okay, wide array of options present over there, okay. The choice of implant which we are planning over here is something like a 4x10, a 4 diameter, a 10 millimeter implant, and for that we are going to go through the 10 millimeter length drills, starting from our pilot to our twist drill and going towards our final drill present over here. And on this meanwhile, I'm going to explain every component of the kit so that you understand the function of every component during the osteotomy. This is a basic exercise for the category A bone, which is a full volume. Our first drill to make a marking and to break the cortical bone is going to be the lance drill. Okay? This is a very sharp pointed drill. This is the only drill, along with the side cutting drill, which is not depth measure. It does not have a stopper for the length. Otherwise, all our implant drills are going to be limited with the particular depth. All right. I take the handpiece and we set the drill over here. Over here, you are not going to see the irrigation because we are not having any danger of burning the bone. Okay. Our RPM set is usually at between 800 to 1200. Before starting with the osteotomy, always check whether the irrigation is working or not. Okay, the irrigation should be present with the cold saline preferably and directly coming on the drill. Okay, so what we do over here is the first thing is do a small marking. That's all we do. Okay, that is the time we do a marking and we do a checkup later. Okay, and we do a marking and we just enter a little bit and then we observe. So we have our marking, and whenever we do the marking similar to that in patient's mouth, we observe from all the dimensions, okay, on the bone level if our osteotomy is correct. Okay, at the crown level osteotomy, crown level angulation, we are going to check with the paralleling pin lot later. But over here, we are checking first for our osteotomy site on the bone level. Okay, I'm happy and satisfied with this, and I'm going to proceed further. Okay, the job of the twist drill, of the lance drill, is to just break into the cortical bone. So over here, actually, I don't have to go full length. I just enter into the cancellous bone, and there you go. My job for the lance drill is over. My next drill is going to be the twist drill, which is of diameter 2.2. Okay, this is an excellent drill, and we are at the most important point in osteotomy. This particular drill determines your angulation in osteotomy. Okay, that has to be, again, as I mentioned, prosthetically driven. And when we place this drill inside the bone, we verify it with the paralleling pin. And if our verification is complete and we are satisfied with the verification with the paralleling pin, all we have to do later after this is a passive osteotomy. That means we are just going to increase the diameter of the osteotomy, and that is done without applying any pressure during the osteotomy. Just observe this thing. The first thing I'm going to do is make an osteotomy. Again, I would like to mention the grasp for a minute for the handpiece. One grasp which you can use is a modified pen grasp, okay, for the handpiece. Another grasp you can use is a palm grasp, okay. Make sure that you unlearn all the techniques of holding the handpiece which you had learned on air rotor. The major function of air rotor is to clear the cavity, to create the cavity, and your major strokes in the air rotor are always going to be brush strokes. They are horizontal. While doing the osteotomy in the implant, your stroke are always going to be only vertical, one in, one out. That's all it is going to be, and that's why what should be stable is your hand while doing the vertical osteotomy. If your hand moves in angulated manner, instead of going vertically down, you're going to have orientation like this. This is known as ping pong hand, and you're going to have a wrong angulation for your implant placement. Okay, make sure your hand moves vertically from your elbow downwards. Okay, and that way you create an absolute vertical control. Okay, over here I'm just using a palm grasp for now. Okay, we are placing our drill at the tip of our marking. While placing a drill on the tip of our marking, we are going to check for the angulation. It is usually the reference which is taken is adjacent teeth if they are not malpositioned, and we are going to place and do an osteotomy along with that particular lines. I can go without any hesitation for full length because this drill allows me only at the depth of 10 plus 1 millimeter. Okay, drilling, go one depth down completely and out. Okay, our osteotomy is complete. Okay, now what we do is the most important thing is that we check our parallelism. Okay, and at that particular time we use this unique paralleling pin. We place it inside. It is just matching our osteotomy. Okay, we see if the angle is satisfactory or not. Okay, if it is not satisfactory, we can always change it at this particular juncture. Okay, we are going to check with the opposing arch if it touches the opposing side or not, and if you can see that it is absolutely oriented towards the palatal cusp of the opposing tooth. I'm quite okay with this osteotomy. I would prefer it little mesially angulated, okay, which I will be correcting in my next drill. Otherwise, buccolingually the osteotomy appears to be absolutely perfect. Okay. If I want to change the angulation of the osteotomy, what I have is another drill, also known as a side cutting drill. Okay, side cutting drill allows me to make the osteotomy and cut it on the horizontal level. So I place this. Okay, again remember that this particular drill does not have a stopper, so be very careful while using this drill with the depth orientation. Okay, I'm happy with this. Alright, now I cannot again check with this particular paralleling pin, because if I place a paralleling pin it will have a mobility like this, because my osteotomy now is changed. Okay, I am going to use the next drill forward, keeping the new angulation in mind, and that is a 3.5 drill. There you go. Once you're satisfied with the osteotomy, next osteotomy is going to be very passive. Then let the osteotomy guide your drill. Rather, all you have to do that you have already reached the full depth, you're satisfied with the angulation. All you have to do is allow the osteotomy to do the increase in diameter. There you go. Okay. Going to keep this thing over here. Coming down to our last drill, that is our 4.0 by 10. Again, last drilling sequence. Over here at this juncture, if I want to check the parallelism, there is an option available. This paralleling pin, which you see over here, works two ways. Okay, one of the side is made for 2.2 drill. The other side, though, is made for 3.5 drill. So we can place this paralleling pin on the reverse way, and you can check the osteotomy as much as possible. Okay, I'm quite satisfied with this osteotomy angulation, and okay. I'm just going to remove this and go ahead with our final drill. Our osteotomy is complete. Remember, if you just imagine that this is to be patient's bone, our criteria for the placement of implant in the freshly done osteotomy is that the osteotomy needs to be filled with the blood within 1 minute. If the osteotomy is not filling with the blood, then something is not right. If the vascularity is compromised and your implant might not integrate. So another thing which we will talk about is the density of the bone. And if I find that the density is very high, I would like to use another drill, and which is an extra, which is present in the kit. These are known as hard taper cortical drill. Okay, there's a last series of that. So if I'm having a 4mm implant, I can use a cortical drill at the 4, this one, and this will increase the diameter slightly of the our osteotomy at the cortical level, and then we don't have to over torque our implant. Now let's see, I found the bone to be quite okay. I don't feel the need right now to use the cortical drill, and I'm going to proceed with the placement of implant. Now understand that implant from the packaging towards the delivery. The implant surface should not be touching anything else except the osteotomy. Okay? The packaging is not to be opened by surgeon, but by the floating assistant, not even your assistant, floating assistant. Packaging of the Osstem implant is quite simple. What we have over here is a 4.0 no mount implant. Do we have a no mount implant? Yeah. Push, and there you open. And this is what we have as a dummy implant. Okay? I'm going to open just to show the packaging. For till now, this is not a sterile packaging, although the inside portion of this is sterile. So remember, your floating assistant will open this and drop it on the sterile trolley. Okay? Just imagine this to be sterile trolley. This entire thing is sterile. Okay? What it has is a implant which is no mount. If it is a mounted implant, what you usually get over here is a cover screw, which is missing in this particular implant. Okay. When we are using a no mount implant, what we need to use next to get the implant is our no mount driver, and that is somewhere here. There are two platforms in Osstem. One is mini for 3 and 3.5 millimeter diameter implants, and for rest of the implants from 4 to 7 ultra wide, we have a regular platform. It's quite easy to open the packaging. We hold this and we have an implant in front of us. Okay, we change the program to the implant mode, and then usual program for implant movement is it's 25 RPM, and I would like a 35 torque, which is so-called rotational primary stability indicator. All I'm going to do now is grab this implant like this. You hear that sound? And that sound ensures us that this complete engagement, the implant is not going to fall. Although, always carry implant from packaging to patient's mouth this way. Always. Okay? So that it does not fall. You carry it to the patient mouth. Remember, till that time, your osteotomy need to be pristine. There should not be any salivary contamination. There should not be any suction done inside the osteotomy, because most of the time your suction tip is also contaminated with the saliva. Over here, the implant needs to be directly placed inside the osteotomy, and that's about it. Okay, let the implant guide, let the osteotomy guide the implant, and your grip on the handpiece needs to be passive in nature. At RPM 425, I am placing the implant, and I have reached the primary stability. If I zoom it, I can see that some amount of implant surface is still exposed, because these are platform switch implant. These implants need to be submerged by 1 millimeter. All I can do now is either increase the torque from the physio dispenser, or I can hand ratchet it. For sake of demonstration with the hand ratchet, I would like to show a hand ratchet method over here. Over here, there you go, you disengage. Again, we can zoom in for the implant, and we can see that the implant is practically at the bone level, but we would like to submerge it by 1 millimeter, and that's the design of the implant. Okay? So, what we will do is we'll take with the hand ratchet torque driver, and there you go. Engage that. We place it in the implant, and slowly, until the marking disappears, we will torque it with the full stability. There you go. Do you have a cover screw? Yes. Cover screw? This is our placement of the implant. Okay, this is submergence, what you can see, of around 1 millimeter. That's what is desired over here. 1 millimeter of submergence of implant, and that's the positioning. It's very good. It's around 1.5 millimeter away from the buccal margin, around 1 to 1.5 millimeter from the lingual, around 1.5 from the distal margin of the first premolar. I'm quite happy with this particular implant placement. Okay, my next move is to put a cover screw or a healing abutment on top of that, depending on the case. Over here we have a cover screw, and we are going to place that cover screw even our hex driver shows the proper angulation. Are we happy with this? Yes, we are happy with this. Okay, so that was about how to place an implant in a category A pristine bone. Okay, our next exercise would be placing an immediate implant at the site 11 or 1-1. Okay, let's observe the socket for a bit. Okay, the choice of implant which we are having over here is of size 4 by 13. Okay, let's observe the socket for a minute over here, because since we do not have a CVCT of this particular model, we can see that the socket level from this end is about 1 to 1.5 millimeter subgingival, but socket from this end, as you can see, goes way inside, somewhere like that, around 6 millimeter. 6 millimeter. And this is unusual because in patient's mouth we will not see a bone level in the palatal side lesser than the buccal side. Okay, it's unusual. Usually you'll see hardly a depth of 1 to 1.5 millimeter for gingival height, and that affects our placement of the implant because we have to consider the lower margin out of the two, that is palatal. Alright, I'm going to make an attempt to place an implant in this imperfect socket. Again, the question comes is that how do we have an engagement inside the socket? Particularly from a theoretical point of view, understand that we engage usually the palatal wall in case of a socket. Since we do not have a scan for this one, we are going to do an arbitrary treatment. Okay, what we have usually is a socket which shows a particular angle. Okay, most of the time the socket angulation and the crown angulation do not coincide, while for the placement of the implant we always follow the crown angulation, that is the prosthetically driven approach. In anterior region, our implant placement or the platform should come more palatally. Why should it come more palatally? Is because tendency of human bone resorption is always buccal. So we are going to lose the buccal bone first. So as much as you can stay away from the buccal side, it's always good for you from aesthetic point of view as well. So we are going to engage the palatal region, okay, and we are going to try to place an implant over there. Okay. Now, again, a 4 by 13 implant. What is suddenly done is that we need to, for the beginners, we need to create a purchase point. The purchase point is required because socket will always keep guiding your drill towards the apex. And because the socket is made up of a dense cortical bone like lamina dura. And over here, we need to overcome that by creating a notch and then creating an osteotomy through that. Angulation which you can create over there can be corrected also prosthetically up to 20 degrees. So that depends on the housing, and I would ask the enthusiasts to please read the Joseph Kahn classification of the socket. Alright. I'm going to engage the palatal wall, and for that I go a little cross, and then I straighten my drill like this, and I go deep. Okay. This is again to just engage the cancellous bone, breaking the cortical bone. Okay. And my true purpose is to just create a purchase point that is done with the lance drill. The drill I would like to go ahead with is a 13 millimeter drill. That is the twist drill. I again engage the same one, and later I'm going to check it with the paralleling pin if it is possible. Again, my platform needs to come on the palatal side. There you go. Sometimes when you're doing anterior region, your drills may get obstructed with the adjacent teeth. If that is the case, you are going to require to increase the height of your drill, and that is done typically with a drill extender. Okay? The drill extension is going to increase the height. It's very simple. Take your drill and put it on the drill extension. As simple as that. As simple as that. See the length of the drill now. Okay? Anyways, so we have achieved the osteotomy. I will try to place a paralleling pin because it's too deep, but this is what we are getting. It's getting pushed by the palatal soft tissues. But in all, this is going to be our position of the implant, which I'm completely okay with. Okay? There you go. Now, I'm going to take out the paralleling pin, and we are going to proceed with the rest of the osteotomy. Understand that whenever you're doing an immediate implant, your submergence level increases to 2 millimeter instead of 1 millimeter. It is because whenever the socket collapses around the implant, you will lose around a millimeter of bone. So that is to be taken into consideration from aesthetic point of view, and you continue with the submergence of the implant. Okay, too much of mess with the styrofoam model. Our next drill is a final drill of 4 by 13 millimeter. Whenever you are doing an anterior immediate implant, or for that matter any immediate implant, it is desired that you get a primary stability. If you want the primary stability in already existing socket, understand that your implant is not going to be 100% inside the bone. It's going to be a certain part of implant which is not going to be inside the bone, because socket is usually always bigger than your implant. And how do we achieve that is by doing under osteotomy or incomplete final osteotomy. Whenever you create an incomplete final osteotomy, you tend to get a good primary stability. Other methods of achieving the primary stability is by densifying the bone, by using densifying burrs, or otherwise using active implants like Osstem TS4. What we have though with us is not TS4 but a TS3 implant. We'll try to give a primary stability for that. Okay, in complete osteotomy, you can observe the osteotomy, how it has engaged, how has it been engaging the palatal wall. Okay, that's the apex over there, that's the palatal wall. And I'll be placing my implant over there. The implant which I have right now is a mounted implant now, which is a little different implant than the no mount, as it exhibits a mount. And it's a design which I usually prefer. You can see the packaging difference with the mounted implant, and it exhibits a mount present over there. The advantages of mount is that you do not come in direct contact with the implant platform, and you can place the implant without actually coming in contact with any part of the platform. Also, mount gives you idea of parallelism. Changing the program. And the speed. This is how we engage the mount. Take out vertically. Again, implant is to be held always like this when you're carrying it to the patient's mouth. Again, implant is raised inside the socket at the desired osteotomy, and there you place it. And we've already got the primary stability. Over here, I would like to increase the torque a little bit. Submerge the implant. I've got the stability, and this is what we have as our implant placement. Now our mount is telling us what can be the angulation for this. There you go. Over here you can use a straight abutment, okay, later, and put a cement retain crown. It would be aesthetic. Or with this stability, strong recommendation is you do a temporization and put an acrylic crown, okay, so that it maintains the architecture of the soft tissue. Okay, this is how we have our implant placement and angulation. Here you go. Okay, these are the two basic exercises for the basic level master class, and right now our students are going to perform the same exercise. Some of them are really new, some of them have never placed an implant, but I believe it would be a very learning experience, and it would be fun to place implant on the model like that. Well, thank you for listening to me, and I will see you again. Hope it was a learning experience for many young implantologists, and I wish all of you the very best. So until next time, okay, thank you Osstem for giving us the opportunity over here to show the students something worth learning, and thank you all my students present over here. Thank you so much, okay, and you have a blessed Sunday and a good evening. Thank you.